Okay, so let's proceed just like last time. Here, a 30-year-old woman has a normal pupillary size on observation, but on shining the light into each eye in turn, the left pupil dilate rather than constrict. So, what is the most likely diagnosis? So, very clear-cut case. She is a lady of 30-year-old, has a normal pupillary size, okay, on observation. But while you shine the light into each eye in turn, this is called flashing light response. The left pupil dilate rather than constrict. So which one is your choice from the list? Is it Horner syndrome? Is it Turner palsy? Is it Eddy's pupil? Is it opioid overdose? Is it Argyll Robertson pupil? Or is it Marcus Gunn pupil? Anybody? Want to take this question?
Sir, sir, I am having problem with screen, sir. Cannot
Screen?
see the question, sir. I don't know about others, but
Really? Okay, wait. Let me share it again.
now is okay, sir.
Now, okay? Okay, fine.
Yes, sir.
Okay. Now, can you answer this? Yes. Now, the last class, I talked a little bit about these things apart from this question, Horner syndrome. Okay, Horner syndrome. What are the four components of Horner syndrome? Yes.
Sir, ptosis, anhidrosis, meiosis, and ophthalmos.
Very good. Excellent. Ptosis, anhidrosis, okay, ophthalmos, and meiosis. These are the four component. And Horner syndrome doesn't have any of these characteristic features. So Horner syndrome is ruled out. Turner palsy. Turner palsy is oculomotor nerve palsy or dysfunction, which leads to mydriasis, not meiosis. So see that left people dilate rather than this is not a feature of Turner palsy. It doesn't happen like that.
Answer is, sir, Marcus Gunn pupil, sir.
Okay, what is that? Can you explain? Maybe you have already done the ophthalmology. So yes, please.
Sir, mainly, sir, there is relative afferent pupillary defect in this type of pupil, sir.
Very good. That
And it is,
yes,
and
please.
it's mainly because of disease of the optic nerve and the retina, such as also in glaucoma.
Good, good. So he's absolutely correct. Just one sentence is enough here. This is afferent relative pupillary defect. So this afferent relative pupillary defect, which occurs in the disease of optic nerve or retina. Absolutely. In this condition, the hallmark thing is the pupil dilate rather than constrict when we flash the light there. So this is Marcus Gunn pupil. But at the same time, please try to know what is the meaning of other pupil also. What is Argyll Robertson pupil? Anybody?
It
Yes, please. Eunice, give chance to another student. Yes, please. Who is speaking there? I cannot see your name here. Please. Yes.
This sir like means the pupil that doesn't react to the light but is constrict during accommodation reflex.
Very good. I can clearly identify his voice. He is Amro. Very good. Excellent answer. Argyll Robertson pupil means when we show the light reflex is absent, but accommodation reflex is present. What is accommodation? Let me ask this question again. What is accommodation? Yes. Anyone?
Yes, sir, this is
Yeah, sure.
when you focus on the like when we seeing a light like far vision, then all of a sudden it's ability to see the near vision clearly, sir.
Good.
There is something.
So what are the components of accommodation? What happens in our eye during the accommodation? Any other? Whoever knows can answer here.
Sir, Three things happened during accommodation reflex, sir.
Okay, what are those?
Meiosis and convergence of the eyeballs, and also the lens size.
Very good. Excellent way of answering. This is so nice to hear. Okay, so when we focusing on the far vision, and when we suddenly bring our eyes to the near vision, what changes occur in our eye? This is called accommodation. You both of you absolutely right. The three things occurring together: the pupil constrict, number one. Number two, there is medial convergence of the eyeball. Both of the eyeball converge on the medial side. Okay, and then the thickness of the lens increases. The thickness of the lens increases. This is called accommodation. Excellent. Okay, so this is the way we discuss here. So let's move on. See this? This is the explanation. The answer is F. This is a Marcus gun pupil. In this, the swinging flashlight, okay, gives you the diagnosis. Now, number two, let's move on. Here is a 41-year-old female develops difficulty in rising from a chair and has a proximal weakness in her leg. So age is 41 year. The main problem is difficulty in rising from a chair and has a proximal weakness in her leg. That's what happened if our thighs and gluteal muscle become weak. She is also noted to have red areas over the back of her finger. This is a very, very important finding. What is the most likely diagnosis? Is it multiple sclerosis? Is it dermatomyositis? Is it common peroneal nerve palsy? Is it disc prolapse on L5? Is it diabetic amyotrophy? And or is it myasthenia gravis?
B.
Okay, please give reason.
Sir, it is a case of dermatomyositis and dermatomyositis and polymyositis. There's an involvement of proximal muscle weakness. And in dermatomyositis, there will be involvement of skin also. So there is a red area over the back of her fingers.
Good, good. So can you tell me the pathological term for this? Red areas in the back of her finger? Yes, your answer is absolutely fine, and the way you are describing is also very correct. Yes, anybody? These are called
Gotran's papule.
very good. Gotran's papule. So very typical features. Excellent. See this? This is the features of proximal myopathy. This is clearly written proximal weakness in the leg. So there is Gotran papules also present. So this has to be a case of dermatomyositis. Now, let me tell you one very interesting case, which has happened in one of my distant relative, not very close relative, but distant relative. She is a girl, a 15-year-old, okay, 15 years of age, and in her, the diagnosis was made not in the beginning, but a bit later. In the beginning, she developed all these rashes in the body, a bit of proximal myopathy, and difficult to breathe. These are the chief complaint of her. So they took the patient here and there, and somebody told him this is a neuronal disease. Somebody told them this is a involvement of the muscles, something like that. But somebody suspected a dermatomyositis and did some autoantibody screening, and the disease was diagnosed. Okay, but the natural history of that disease in her, it was so rapidly progressing that within few weeks her lungs were completely damaged, the damage of the lung, and she died from that illness. Even the best center could not save her. So sometimes dermatomyositis can be a very, very serious disorder. Okay, the answer is B. This is a Gotran papule. See there, very typical finding. Please try to remember this. Now, number 3. A 46-year-old man presents with weakness of his left leg. On examination of his sensation, he has impaired proprioception and vibration in the left leg and impaired pain sensation in the right leg. Now see that? So age is 46 year, male, weakness of his left leg. That's the chief complaint. On examination, you have found, okay, he has impaired proprioception and vibration of the left leg and impaired pain sensation on the right leg. So see this, weakness is also present on the left leg. Impaired proprioception and vibration is also present in the left leg, but pain sensation is impaired in the right leg. So what is the most likely diagnosis? Is it L5 disc prolapse? Is it myasthenia gravis? Is it Charcot-Marie-Tooth disease? Is it vitamin B12 deficiency? Or is it Brown-Sequard syndrome?
E.
E, Brown-Sequard syndrome. Yes. What you got? Yes. What you got from here?
The weakness and the dorsal column and sign will be present on one side, and the pain and the temperature will be present on the opposite side, sir.
Good. So this is Brown-Sequard syndrome. Excellent. The description itself is so typical of the condition here. He is absolutely right. Brown-Sequard syndrome manifests like that. Okay, please mute yourself. Brown-Sequard syndrome manifests like that. In this condition, there is hemisection of the spinal cord. Hemisection, and in this patient, the hemisection of the spinal cord has occurred on the left side. Okay, on the left side of the spinal cord. So because of this, the same side, muscle weakness has occurred, and then the vibration and the impaired proprioception, loss of vibration, I should say, and impaired proprioception also occurred on the same, because this is caused by or carried by the dorsal column tract, and dorsal column tract, they don't cross over at the same site. They go way high up and cross over in the medulla. That's why there is no cross type of lesion. Okay. So similarly, corticospinal fiber, they have also already crossed in the medulla. So same side lesions have happened. Whereas the fiber which carry pain and temperature sensation, or they are called spinothalamic fiber, they cross exactly at the same site of the lesion. And that's why the pain sensation, the impaired pain sensation has occurred on the right side. So this is the explanation. The cause of the Brown-Sequard syndrome may be some trauma, okay, and some compressive lesion on that side. Sometimes the question may be asked like that. Now see there, this man has the classical features of Brown-Sequard syndrome with dissociated sensory loss. That is, the dorsal column loss ipsilateral to the lesion, and spinothalamic tract occur contralateral to the lesion. Never forget this. Now, if you have paid attention to this type of discussion, trust me, if this type of question is asked in your future exam, you cannot miss the answer. Some point will flash in your mind, and yes, this is what I have studied before, and this is the correct answer. This is the importance of paying attention in this discussion. Number 4. A 59-year-old lady with grade 3 congestive cardiac failure has become increasingly short of breath despite excellent control of her cardiac function and no deterioration in her ejection fraction on echocardiography. A chest radiograph is reported to demonstrate bi-basal lung fibrosis, which was not present 2 years earlier. Which of her cardiac medication is the most likely cause of the fibrosis? So this question is, pharmacologically based. So let me clarify once again. She is a 59-year-old lady. She is having grade 3 heart failure. What do you mean by grade 3 heart failure first? This is NYHA grading. According to NYHA grading, what is grade 3? Yes, please. Now remember, NYHA grading. Yes.
Sir, in grade 3, the patient is having become dyspneic and having this feature on just on minimal exertion like brisk walking or.
Yeah, he's right. Minimal exertion is the correct term. Very good. Grade 4 is the most severe one at rest, that is grade 4. Grade 3, only on minimal exertion also patient becomes breathless. Grade 2, moderate exertion, and grade 1, severe exertion, the patient becomes breathless. In all these cases, the heart disease is already present in the patient. Okay, this is called NYHA grading, very important concept from the cardiology. Now, see this, she is having shortness of breath despite excellent control of her cardiac function, and there is no deterioration in the ejection fraction, which is maintained. Chest radiograph shows bilateral basal lung fibrosis, which was not present 2 years earlier. So clearly, one of the medication which was used is causing the side effect. So which one is that medicine? This is straightforward question here. Which is your choice? Very easy.
Midron.
Midron, sir.
Exactly. Exactly. This is amiodarone. Okay, amiodarone. Atenolol. Which type of drugs is atenolol? Which drug is this?
Beta blocker.
Very
Beta
good.
blocker.
Beta blocker. Cardioselective type of beta blocker. Atenolol. Which drug is spironolactone?
Diuretic.
Diuretic.
Diuretic. Potassium sparing diuretic. Potassium sparing diuretic. What is digoxin? Which type of drug is this?
Positive inotrope.
Exactly.
Yes.
You can say positive inotropic agent or cardiac glycoside, whatever way you answer. We just want to hear this. We want to check our student whether they know these things or not. Okay, just one answer is enough. Amiodarone,
Calcium.
Class 3 antiarrhythmic.
Very good. Class 3 antiarrhythmic drug. Class 3 antiarrhythmic drug, and this drug has so many side effects. This drug can cause hyperthyroidism and hypothyroidism both because of different mechanism. This is iodine containing drug. So, thyroid disorder is one of the important side effects of this drug. And this drug can also cause lung fibrosis, which is the question here. And what is atorvastatin?
Lipid lowering drug. HMG coenzyme inhibitor.
Exactly. Lipid lowering agent. Okay. Lipid lowering agent or HMG-CoA inhibitor. Very good. This is the excellent drug, very, very commonly used drug in the clinical practice to decrease the lipid level, especially cholesterol. So these are the important points. Okay. So you can read this later on. Amiodarone can lead to pulmonary fibrosis. Don't forget. That is the take-home messages. Now, number 5. Okay, these are a bit of interesting type of thing. So please take a piece of paper and a pen in front of you, and probably you need a bit of time for this type of question. A 45-year-old oil rig worker is admitted with fever and shortness of breath following a return from a secondment overseas. So he was working there and he returned with these features or problem. 4 days into his admission, he develops worsening symptom and a chest radiograph reveals a pleural effusion or pleural collection. A pleural tap is performed due to concern this may represent an empyema. Okay, so they were concerned. They were concerned about empyema, so they have decided for the pleural tap, also known as thoracocentesis. Which of the following results is most fitting with an empyema? So you should choose one of the option which is most fitting with an empyema. Okay, now see here and try to solve it.
Option B.
Option B. Okay, option B. Why option B? Give reason, please.
Sir, high protein and high LDH with acidic pH. These are the specific feature for exudative effusion.
Very good. Yes, directly, you chose the option and then gave the correct answer as well. Very good, excellent. The most important point here, you have to, choose is pH. pH should be highly acidic first. Okay, in pus, pH should be highly acidic. So see this, the last three options, pH 7.45, 7.45, 7.38. These are not highly acidic pH at all. It is not dropped from 7.35, so I can easily exclude them. C, D, and E are gone. Okay, only remaining options are A and B. Now see here, protein should be high in exudate empyema, or pus collection is a type of exudate, right? So it's exudate, so protein collection should be higher. And if I compare A and B, in B it is 3.8, this is gram, okay, gram per deciliter, so it is of course high. And look at LDH, it's almost the same, it doesn't matter by the difference of 8. So B is the correct answer here. This is the way you reach to the correct diagnosis or the correct option. Let's see the explanation here. It's a B, okay. A pleural effusion is a collection of fluid in the pleural space between the parietal and serosal layer of the pleura. Serosal means visceral layer. Pleural aspiration or thoracocentesis is usually necessary to determine the cause and nature of the effusion, whereby a sample is sent for biochemical analysis, bacteriological culture, and microscopic examination. This is called pleural fluid analysis. So every student should know how to interpret pleural fluid analysis report. That is the concept which is provided by this question to us. The effusion can then be classified into a transudate or exudate depending on its biochemical characteristics. If protein is more than 3 gram per deciliter, we call it exudate. If it is less than 3 gram per deciliter, we call it transudate. Okay, pH is measured, and when there is concern regarding empyema, typically has a pH less than 7.2. So this is an important knowledge. Now, what is the treatment of this patient? Yes, anyone? Treatment. What treatment should we go for?
Sir,
Sir,
two kind of treatment, like one is symptomatic and one is definitive, sir. Like first, that pus should be removed, should be drained first, and should find out the underlying cause and treat that also.
Okay, so he said pus should be removed and then find the underlying cause and treat. Yes, I want to hear another answer. Yes, please. Somebody is trying to answer here. Yes.
Also, we can give antibiotics.
Can give antibiotic. Yes, that's a symptomatic treatment. Good, good. Now see here.
Sir,
Yes, yes, please, please.
sir, it may have many causes, sir. Same like it may be because of lung cancer, or maybe because of mesothelioma, and or maybe TB or something. So when treating underlying causes, we can treat it. And as he said, the aspiration is also important.
Okay. Now, this is a case of empyema thoracis. So the first treatment here is removal of the pus. Until and unless you remove the pus or aspirate the pus, patient is not going to get better. So, and usually this pus is very thick, thick type of pus. So simple aspiration alone may not be enough. So you have to put tube thoracostomy. You have to put the chest tube drainage there. This is known as tube thoracostomy drainage. That has to be done. Without that, patient is never going to get improved. After that, this is cause of infection, bacteria. So antibiotic therapy is also very, very essential. Broad spectrum antibiotic has to be given after culture and sensitivity test. And third one, absolutely acceptable answer. What is the cause of this? What is the predisposing factor there? What are the risk factors? Let's find out, and also going for the management. Now, okay, so we have already talked about this, so I'm going to skip this now. Now, number 6. See that? 68-year-old pub landlord and lifelong smoker. Okay, so see this. He's 68-year-old and he has smoked his whole life. He's admitted with lethargy and drowsiness. Lab tests reveal results which are consistent with syndrome of inappropriate antidiuretic hormone secretion. So it is SIADH. And a chest radiograph demonstrates a 3 centimeter right upper lobe mass. Okay, so there is a definite mass which is shown by chest X-ray. And he is a lifelong smoker, and he is a bit older already. He is due to undergo a CT-guided biopsy of the mass. So what is the histological subtype? Most likely to be. So you already know this is a lung cancer or bronchogenic carcinoma because of the typical clinical finding. But the question is not that. The question is which type of the bronchogenic carcinoma is this? Is this bronchoalveolar cell carcinoma? Is it squamous cell carcinoma, pulmonary hematoma, pancreatic carcinoma, or small cell carcinoma? Anybody?
Small cell carcinoma.
Small cell carcinoma.
Okay. Small cell carcinoma. Why?
Because, sir, here they mentioned about the syndrome of inappropriate ADH secretions. Sir, it mainly because of occurs in paraneoplastic syndromes, sir, and that is small cell carcinoma is actively secreting some of the substances. Sometimes it is ADH and sometimes it is ACTH and others, sir.
Okay. So this is paraneoplastic syndrome. What is paraneoplastic syndrome? What is that?
Means, sir, they are actively secreting many substances, sir.
Good. They are actively secreting the Yunus.
They are actively secreting the substances. In this case, it is secreting ADH, sir.
Very good. Now, let me clarify this. He is absolutely, correct. A little bit of explanation is necessary here. This is a clear-cut case of lung cancer first. Okay, clear-cut case of lung cancer. That is number one. A student who cannot identify this as a lung cancer, now that student should see this type of cases more straightforward case. Okay, the question is not that though. The question is which type of the bronchogenic carcinoma is this? Now there are, according to the textbook, different explanations or different types are highlighted. Bronchogenic carcinoma can have different type. One is large cell, another is small cell. Okay, large cell and small cell carcinoma. Now, small cell or non-small cell also you can answer like that, or you can answer straightforward like squamous cell carcinoma, uh, alveolar cell carcinoma or adenocarcinoma. One of the subtype is bronchoalveolar carcinoma, then small cell or odd cell carcinoma, isn't it? Something like that. So among them, the small cell carcinoma is associated with a lot of paraneoplastic syndrome, but sometimes even squamous cell carcinoma can be associated with some type of paraneoplastic syndrome. Okay, so the answer is right. So what is paraneoplastic syndrome then? It is a special feature of malignant tumor, some of the malignant tumor, where the malignant cell produce some type of substances, and those substances, okay, can cause clinical effect far away from the tumor site. Now see here, they cause clinical effect far away from the tumor site. For example, bronchogenic carcinoma is present in the lung, but the clinical effect is present somewhere else. This is known as paraneoplastic syndrome. So answer is E, absolutely correct, and the different explanations provided are also, appropriate. Okay. Now a little bit more knowledge here regarding SIADH. SIADH involves the inappropriate secretion of ADH, which leads to retention of water and hyponatremia. This hyponatremia is called dilutional hyponatremia. Okay. Regarding the treatment, I just restrict the water here. You don't need to give sodium. Don't think sodium level is less here, so let's give sodium. That is not the treatment. This is because of retention of water. So if you restrict the water, everything will be back to the fine, normal. SIADH may be caused by many tumors like prostate, thymus, pancreas, and even lymphoma. However, the most common tumor causing SIADH are small cell carcinoma of the lung. Okay, very nicely told. So let's move on. Now, number 7. A 36-year-old woman is admitted with shortness of breath and pleuritic chest pain following a 16-hour flight to London from Borneo. Okay, Borneo belongs to Malaysia, Borneo Island. The working clinical diagnosis is a pulmonary embolus and a CT pulmonary angiogram is requested. What is the most important consideration before the test can go ahead? Now see there, so this is a CT pulmonary angiogram is planned, right? So we have to give certain dye to do this test. So which is the most important consideration before the test can go ahead in that lady? Normal liver function test, normal serum glucose, normal renal function, normal thyroid function, or if she is on the oral contraceptive pill. Anyone?
Normal RFT.
Okay. Why, Aman? Any reason?
That dye which is given for a CT pulmonary angiogram can be toxic for a kidney, so we should do RFT. If it is normal, then we can go for a CT pulmonary angiogram. If it is not normal, then we have to consider some other options.
Absolutely. Now, wait, the answer is, this is an easy question actually, but one question I like to ask you, why this chance of pulmonary embolus is high here? What is the reason? Yes, why? Yes, immobilization. Very good. Immobilization for a longer time may be a feature of, or a risk factor for deep vein thrombosis. And deep vein thrombosis is a risk factor for pulmonary embolization. Okay, that is a clear-cut risk factor given here. And to diagnose that pulmonary embolization, the CT pulmonary angiogram is planned. Okay, so to do that, we need to give a dye inside the system, and this dye is handled by the kidney. So make sure the renal function test is normal, then only you can go for this test. Otherwise, you cannot do. So that is a correct answer. So normal renal function. Okay. Now number 8. A 56-year-old chronic smoker present to his general practitioner with lethargy and a change in appearance like rounded face and striae, increase in weight, predominantly around the trunk, and increased blood pressure. See this. What is the most likely diagnosis? Now, please analyze this clinical feature and make the clinical diagnosis first, okay? Then only you can go for etiological diagnosis. Remember, diagnosis can be of different type. When we examine the patient, we make clinical diagnosis. Then after that, we think about what is the cause of this, disease or the diagnosis which I made. What is the etiology? That is the etiological one. So what is the clinical diagnosis first according to his clinical features here? Yes?
Cushing syndrome.
Cushing syndrome. Excellent. This is Cushing syndrome case. So change in appearance means probably moon face, okay, buffalo hump and all these things. Abdominal striae, very typical there. Increase in weight, especially this is called truncal obesity, okay. Nevertheless, there is a lot of fat deposition around the trunk, so the person gains weight, though the limbs are very thin. So increased blood pressure, increased blood sugar, and all those things are there. So what is the most likely diagnosis? So which of these following can lead to Cushing syndrome?
C.
C.
Okay. It's C, small cell carcinoma. So bronchoalveolar cell carcinoma, again the answers are similar. squamous cell carcinoma, small cell carcinoma, pleural fibroma, or mesothelioma. So what is the answer here? Okay, see that the answer is small cell carcinoma again. They're absolutely right, and the reason is also same. So I don't need to ask the explanation again, because this is the bronchogenic carcinoma, which is associated with uh, ACTH secretion most of the time. So an example of paraneoplastic syndrome again. They are also known as port cell carcinoma. Okay, because of this their appearance. Port cell carcinoma account for 20 to 30% of all lung cancer, and this is associated with smoking. Remember this, smoking is strongly associated with small cell carcinoma, which lung cancer is not that commonly associated with smoking. Means even in non-smoker that lung cancer can develop. Which is that? Yes, any guess?
Sir, I think it's adenocarcinoma.
You're right. This is adenocarcinoma. Absolutely. Squamous cell carcinoma and small cell carcinoma are very, very strongly associated with smoking, whereas adenocarcinoma is also caused by smoking. I'm not saying that, but we have seen the person who has never smoked in their life can also develop lung cancer, and that is usually adenocarcinoma. Now, these are the different types of substances secreted by small cell carcinoma of the lung. It can secrete ACTH in this case. Let's move further. Let's talk about number 9. This is 48-year-old man with history of ulcerative colitis, attends the gastroenterology clinic for his regular review. So already diagnosis is given. This is a case of ulcerative colitis, and going for the regular review in gastroenterology clinic. Over the past few months, his bowel symptoms have been well controlled, but he has suffered from itching and fatigue. So some new problems have started in him, itching and fatigue. See there. But the bowel complaints are fine. The following blood tests are ascertained. These investigations have shown the following features. You can see there now the investigation. WBC count, okay, or white cell count is 5.1. This means 5,100, and platelet count is 278,000. Okay, 278,000. So what is the comment on this? Is this normal? What about the WBC count and the platelet count?
C is normal, 4 to 11, and platelet is 150 to 450 is normal.
Fine, absolutely correct. So WBC count 4,000 to 11,000 normal, and platelet count 150 to 400,000 is normal. So fine. Autoantibody screening was done, and it shows perinuclear antineutrophilic cytoplasmic antibody. This is a special type of antibody which is positive. This is called p-ANCA antibody. Okay, antinuclear antibody also positive, and anti-mitochondrial antibodies are negative. Now, let me remind you, this p-ANCA is associated with ulcerative colitis. Okay. This is the special antibody which is present in ulcerative colitis. This antinuclear antibody is a very sensitive type of antibody in any connective tissue diseases or connective tissue disorders or autoimmune disorders. So non-specific. Okay, it may be present in so many different conditions. Whereas anti-mitochondrial antibody is present in primary biliary cirrhosis. Okay, specifically present in primary biliary cirrhosis. We'll analyze this a bit later also. Bilirubin is 65 micromole per liter. This is the normal value. So it is higher than normal. You can clearly see here. ALT, alkaline, okay, saying 75, isn't it? Sorry, this is alanine transaminase, ALT. AST, aspartate transaminase is 64. See this? This is the normal value, so it is elevated. 64. This is also elevated. is a normal value is less than 48. And alkaline phosphatase, which is the important type of enzyme here in this case, is high. Normal is 100 less than 130. And GGT, gamma glutamyl transpeptidase, 300. Normal is less than 60. So what is the interpretation of this liver function test?
Sir, obstructive jaundice.
Okay, he's saying obstructive jaundice. Yes. Any other?
Pathology
Here
in
the
biliary tract, sir.
Yes, please, a bit louder. Yeah.
Sir, this is a case. This is a case of
Sir, the ALT is high.
with IBD and causes obstructive jaundice, which is having these features like hyperbilirubinemia and elevated alkaline phosphatase and gamma glutamyl transferase, which with itching sensation and clay color stool and dark color urine.
So he says this is a case of obstructive jaundice or cholestatic jaundice, and the risk factor is given there. It is a case of ulcerative colitis. Now look at the clinical feature, itching, very important clinical feature given of cholestatic or obstructive jaundice, and the liver function test have confirmed that bilirubin is high. Okay, ALP is more higher, and GGT is also high. Whereas ALT and AST are also high, which can happen even in cholestatic jaundice. It depends how bad is the obstruction there. So the diagnosis is cholestatic jaundice till now with ulcerative colitis. Okay. Now let's see what they have given further. Now, which of the following is the most likely diagnosis? The diagnosis is asked: cholelithiasis, hepatocellular carcinoma, primary sclerosing cholangitis, viral cholangitis, or primary biliary cirrhosis. Now you can choose the correct answer. I'm sure every student can choose now if they have listened to my discussion here. Yes, which is the answer?
C.
Exactly, it's C. It's called primary sclerosing cholangitis, PSC, which is a known feature, in case of ulcerative colitis. This is known as extra-intestinal manifestation of ulcerative colitis, primary sclerosing cholangitis. There's a strong connection. And P-ANCA is very important autoantibody which is present here in PSC. It can lead to obstructive jaundice because of inflammation of those biliary duct. So everything is, matching with the description here. So the answer is primary sclerosing cholangitis. Okay, so let's talk a little bit about this. Let's utilize this opportunity. This is a chronic liver disease resulting from inflammation of the bile duct, which is associated strongly with ulcerative colitis. The gamma glutamyl transpeptidase and alkaline phosphatase level are usually the most elevated of the liver enzyme, although rises in transaminase like AST and ALT can occur, and bilirubin in more advanced disease. The disease is believed to be autoimmune in nature, definitely. Hence, both anti-nuclear antibody and P-ANCA may be positive. Primary biliary cirrhosis is also a type of autoimmune liver disease, but it is strongly associated with anti-mitochondrial antibody. Never forget this. ANA is very sensitive type of antibody, but not specific. So it may be present in many different conditions. In SLE, also ANA is present. We know that. So in this condition, also ANA may be positive. So it doesn't give us the diagnosis. Now, number 10. A 25-year-old man, the age is quite young, had been hit on the head by a cricket ball, and then about 1 hour later had lost consciousness. So he was playing cricket and he was badly hit by the cricket ball right on the head, and about 1 hour later he lost the consciousness. He became comatose. On a CT scan of the head in accident and emergency ward, a room, he had a hemorrhage which is shaped like a convex lens. It's seen on the CT. What is the most likely cause? This is a straightforward question. Subdural hematoma, subarachnoid hemorrhage, extradural hematoma, brainstem hemorrhage, or intracerebral hemorrhage? What is the answer?
C.
Yes?
Extradural hematoma.
Extradural hematoma.
Extradural.
Yes. Yes. Can anybody explain, please?
Yes, sir.
Because sir,
Yes, Abdullah. Yeah. Hmm?
yeah, because the hemorrhage shape is conventional, and that is a typical finding on the extradural hematoma, sir.
Very good. Yes, this is a very specific question. The typical shape which is seen on CT scan, that is convex shape or convex lens shape like bleeding, occurs in extradural hemorrhage. Now a little bit more discussion is needed here. Okay.
Yes, sir.
What is this clinical feature which is provided to you here? What is this called?
Sir, lucid interval is, they are talking about that, sir.
Okay.
That
What
is
is
a
lucid?
typical feature.
What is lucid interval? What is that?
Sir, it is the how to say, the time of consciousness between two unconscious states, sir.
Good. So only one unconscious state is given here. Okay. The another is
Yes,
not.
sir.
The another is not provided to you. But please remember that in the beginning, it just may be a cerebral concussion. Just a concussion may be there, and people take that very easy, very lightly. A bit of dizziness occur, and they may lie down for a few minutes, and they are ready to go again. They feel all right, and this is a false type of well-being situation, isn't it? Something horribly wrong is going inside the head, but actually people don't realize that, and they continue to do whatever they're doing, and then after certain time, when the bleeding is maximum, then they can be comatose again. So the interval between these two episodes, okay, first maybe just a concussion, and second is a frank coma, is called lucid interval. This is highly suggestive of extradural hematoma. This is a typical case scenario. Don't forget, so many cricketers they have died, because of this type of incidents. Extradural hematoma is a very serious condition. What is the treatment? Yes, treatment. What treatment should be done now after you diagnose it?
Removal of
Surgery.
Exactly. Surgical evacuation of the clot. And what is the source of the bleeding here? In this case, from where the bleeding comes?
Most probably,
Middle
sir, it
meningeal.
is
Middle
because
meningeal.
of
Medial
the,
meningeal.
yes.
Excellent. Middle meningeal artery. See that? Though this is a case now, next time, any of these, questions can be asked to you. I can simply ask, okay, which is the most common source of bleeding, and by giving a middle meningeal artery as one of the option. Which of the following is a typical feature? Asking lucid interval here. So this is the way of learning, okay? Now don't only focus in only one part of the aspect. Try to include some other features here. Very good. So this is extradural hematoma. Now, number 11. All of you please focus here. This is a 45-year-old man, presents with a 1-year history of difficulty walking, as well as pain and sensory disturbance in the upper limb. So difficulty walking, as well as pain and sensory disturbances in the upper limb. 45-year-old male. On examination, he has a spastic paraparesis, and in the upper limb, decreased sensation to pain in a cape-like distribution, that is over the shoulder, the lateral aspect of both arm and both thumb, as well as index finger, with intact proprioception and vibration. Now, this is a little bit confusing case for many students because of the amount of neurological problem included here. So if I want to solve this type of case, what I do? I will take a paper and pen with me and write this important feature. and then think about it. What is happening here? What type of features are they? Okay, then I can reach to the diagnosis. And of course, the diagnoses are provided here. One of that is a correct one. What is the most likely cause of his problem? Multiple sclerosis, syringomilia, vitamin B12 deficiency, anterior spinal artery infarction, and tuberculosis. Now, let me explain a little bit, then the answer is very easy for you. So what is happening here? See this. Shoulders, the lateral aspect of the arm, which reaches thumb and index finger with intact proprioception and vibration. So the area of the involvement here, okay, is cervical part of spinal cord. Okay, cervical part of the spinal cord. Remember, because all these nerves comes from there. That is the first thing. And having said that, the proprioception and vibration, which is the feature of dorsal column tract, they are not involved. Second important point. The third one, in the lower limb, there is spastic paraparesis. Okay, this is a feature of upper motor neuron lesion in the lower limb. Whereas in the upper limb, there is decreased sensation to pain. Okay, just the pain. So spinothalamic tract fiber are involved. So like, see this is how I am, giving hint or clue to you. So what is the answer now?
Syringomilia.
Okay, syringomilia. So syringomilia is the correct answer here. Yes, you're right. Syringomilia occurs in that area which I've just discussed, and exact clinical features are like this, syringomilia. Now, let us, this is a very new things for you. So let's take the opportunity to talk a little bit about syringomilia. Please pay attention here. Syringomilia is a disorder in which a cyst or cavity forms within the spinal cord. It is also known as syrinx. Syrinx means cavity, a cyst. It can expand and elongate over the time, destroying the spinal cord. So this is an enlarging type of cavity or cyst which can damage the neurons which are present there with a lot of clinical features. The damage may result in loss of feeling or sensation, paralysis, and weakness, and stiffness in the back, shoulders, and extremities. These are the important features. Syringomilia may also cause a loss of ability to feel extremes of hot or cold. See, look at the features of spinothalamic tract again, especially in the hand. It may also lead to cape-like bilateral loss of pain and temperature sensation along the upper chest and arm. This is the most important clues for us, because the syrinx is, enlarging on the lateral aspect, on the lateral side, it is enlarging. So the fiber which are crossing over, this pain and temperature carrying fiber or spinothalamic tract fiber, are damaged because of this lateral expansion of the cyst. It may also expand posteriorly, a little bit posterior, not that much. That's why the dorsal column tract fibers are still intact. Okay, and because of the lateral involvement, the spastic paraparesis is also seen. Now, let me show you a picture here. I've included a picture. Okay, so see here. This is known as cape-like distribution of pain and temperature loss. See this. The upper limbs are affected like that. The anterior part of the chest, the shoulder, and the whole upper limbs are affected. And this is how the syrinx looks like. This is a schematic diagram, but very informative one. This is a cross section of the spinal cord. You can clearly see here. Okay, and this is the cyst or syrinx which is developed, and it continue to develop on the lateral side and destroy the nerve fiber there. Let's move on. Another question. Question number 12. A 67-year-old woman had a 3-month history of weakness of her left leg, and a 1-month history of weakness in both arms. So 3-month history of weakness of left leg and 1 month history of weakness in both arms. Okay, please correct it. She felt things were getting progressively worse. On examination, she had wasting and fasciculation in all 4 arms. Okay, she was weak in all 4 limbs with brisk reflexes throughout with upgoing plantar. She had a normal sensory examination. What is the most likely diagnosis? We have done this case, probably in the last class or before that. We discussed this. So anybody can, solve this one? Yeah.
I think it's a motor neuron disease.
What clues you got from here?
Sir, like there are only motor problem without sensory involvement, and there is a upper motor neuron sign and lower motor neuron sign, like wasting of the muscle and fasciculation are lower motor neuron sign, and that brisk reflexes and upgoing plantar upper motor neuron signs.
Very good. So he, correctly explained all the points. Okay. So this is a case of motor neuron disease. Now, let me take this opportunity to teach my students, if somebody is still confused regarding this, what are the features of upper motor neuron and lower motor neuron features? So please pay attention. UMN lesion. UMN lesion means involvement of upper motor neuron fiber. And upper motor neuron fiber always starts from the cerebral cortex and they end, okay, and they end on 2 important areas. Okay, so where they end, yes, where are those shells where they
These
end?
are corticonuclear fibers and corticospinal fibers, like from the cortex to the nucleus and the brainstem, or from the cortex to the spinal cord.
Exactly, it's absolutely correct. So first of all, everyone should understand what is UMN fiber and what is LMN fiber. Then only the pathology comes. So upper motor neuron starts from the cerebral cortex, and they can either end, okay, on the the nuclei of cranial nerve. The nuclei of cranial nerve. These are called corticonuclear fiber, and they can also end at the anterior horn shell of the spinal cord. So we call them corticospinal fiber. So any one of these can be damaged, and we still call it upper motor neuron lesion. This is the very, very important point. The second one is a lower motor neuron. Now, those nuclei of the cranial nerve are the parts of lower motor neuron. Okay, they are part. And after that, the whole nerve bundle is a part of lower motor neuron till it terminates, okay, in the periphery. That whole thing is lower motor neuron. This is regarding the cranial nerve. Regarding the peripheral nerve, okay, the anterior horn shell is a part of that, and the whole spinal nerve is a part of that. Now let's come to the pathological aspect. What happens if this upper motor neuron is damaged? The person will have spasticity. Increased tone is called spasticity, and it has a specific feature, spastic type of weakness or paralysis. Paralysis also occur here, okay, but that paralysis is not as dense, as lower motor neuron lesion. Okay, it has got Babinski sign. Babinski sign. Babinski is upper going or upgoing plantar. Okay, never forget this. Regarding the reflexes, they are exaggerated. They are exaggerated. Sometimes they also have clonus. Clonus is also present there. Clonus is exaggerated reflex. Too much exaggeration is there. Okay, so tone is included, power is included, Babinski sign is included, and exaggerated reflexes are included. These are the hallmarks of UMN lesion. Now, what about LMN? Regarding the LMN lesion, okay, we have flaccidity. flaccidity or decrease in tone is called flaccidity, also known as hypotonia. You can understand like this. Paralysis is a denser one here. This paralysis is much more, severe than the upper motor neuron one. Okay, paralysis. Then all these reflexes are absent. Absent reflexes. Absent reflexes. Right. Okay. Then of course the clonus will be absent here. There is no clonus because of the absent of the reflexes. And one of the important feature which is present here is called fasciculation. Fasciculation, which is provided as important clues for lower motor neuron fibers. Fasciculations. Okay, so these are the ones. So clear cut, this is a combination of upper motor neuron and a lower motor neuron feature, which is a hallmark of motor neuron disease. Like amyotrophic lateral sclerosis is the wonderful example here. Now, question number 13. A 53-year-old woman has a 1 week history of sudden onset of weakness of the left side of her face. See this? Sudden onset weakness of the left side of her face. On examination, she has a left-sided facial droop with difficulty on the left side in raising her eyebrow. So facial droop is also on the left side, and difficulty to raise her eyebrow is also on the left side. Closing her eyes is also a problem, and blowing out her cheek is also a problem on the same left side. So what is the most likely diagnosis? A straightforward case again. Is it myasthenia gravis? Is it lacunar infarct, which occurs inside the brain? Is it multiple sclerosis, a type of autoimmune diseases? Is it Bell's palsy, which is an idiopathic condition? And is it middle cerebral artery infarction? Yes?
D.
Bell's palsy.
Bell's palsy. Okay. What is Bell's palsy?
Sir, it is
It's
idiopathic.
lower motor neuron facial palsy.
Yes, it is idiopathic lower motor neuron involvement of facial nerve. Idiopathic lower motor involvement of facial nerve. Excellent. If you say that, the whole answer is there for you. Now, everybody, whoever are, watching here or listening, please, this is a very, very important case scenario for you. We can ask the question in a many different way, but if you understand the concept, you will never, attempt it wrongly in your future. See this, sudden onset weakness of the left side of the face. On examination, left-sided facial droop means the angle of the mouth has been lower on that side which is paralyzed. The normal side of the face, the muscles are normal there, they are normally contracting. So the angle of the mouth is always higher on that side. This is a very important feature. This will make us, give us some clues for the diagnosis. And then she cannot, raise her eyebrow. She cannot even close the eye actually. Okay, the eye remains open all the time. And what is the problem? If the eye cannot be closed or remain open all the time, what may happen?
Exposure keratitis.
Exactly. This is known as exposure keratitis. Very good. That's why, one symptomatic treatment we have to go in case of Bell's palsy is during the night time when the patient goes to sleep. We need to close the eye with the help of pad. We should, put some artificial tear drop on the eye, then padding the eye. This is one of the special treatment in this case, just to prevent from the exposure keratitis development. Very, very important feature. And then blowing out her cheek is also impossible here because buccinator muscle is paralyzed. So all these features are there. Now, before I move further, I'd like to explain one important point here. Sometimes what happens, even in upper motor neuron disease or lesion, the face is paralyzed. So what is the difference between UMN involvement of the face and element involvement of the face. Anybody?
Yes, sir.
Yes, Eunice?
In upper motor neuron type of lesion, the lower face will be paralysis only, sir. But in lower motor neuron type of facial paralysis, the whole half of the face will be paralysis. Same like in upper motor neuron paralysis, only the angle of mouth will be deviated, but the wrinkling at the forehead will not be affected. But in case of lower motor neuron, the both upper face and lower face will be affected, and the margin in between upper and lower face uh, is the border of the eye. This is the
Very,
lateral canthus of the eye.
very good. He has explained it so nicely, make it everything so clear here. So please, everyone, listen here. Let me repeat whatever he has told here. Now, I should, be certain what is the boundary of the upper part of the face and lower part of the face. That's the first thing. Upper part of the face versus lower part of the face. Now, eye is included as a part of upper face. Forehead is included as a part of the upper face. Whereas, okay, blowing the cheek and angle of the mouth are the important part of the lower part of the face. Now, why? Why this differentiation is important? Because in upper motor neuron lesion, okay, those corticonuclear fiber, remember, we just talked about them. They supply the bilateral facial nerve nuclei. They supply both facial nerve nuclei. Okay. As a result of that, only the opposite lower half of the face is affected in case of upper motor neuron lesion. The part of the facial nerve nuclei, let me make it even more clearer to you. The part of the facial nerve nuclei which supply the upper part of the face on both sides has bilateral innervation. Now it is making things clear. That's why the upper part of the face is not involved in upper motor neuron lesion. Only the contralateral lower half of the face will be affected. Now, I know the theory, but practical knowledge is also important. So how I examine that, isn't it? Look for the angle of the mouth. If it is drooping downward, if the patient cannot blow the cheek, okay, if the opposite angle of the mouth is pulled upwards, if the saliva is drooling from the corner of the mouth, these all are important features of facial nerve paralysis, mainly upper motor neuron. Whereas in lower motor neuron, the same side is affected and the whole face is affected. Person cannot close the eye will remain open. The frowning is disappearing. The angle of the mouth is drooping downward. Saliva is drooling from the corner of the mouth. Patient cannot blow. Everything is there. So these are very, very important point. So differentiate between upper motor neuron lesion on the face and lower motor neuron lesion on the face. If you are still not clear, okay, what I suggest is follow some of the good neurology textbook and try to make your concept very clear. Okay, this is very, very important part of neurology. Now we are coming, towards the end of this, important discussion. Still, I have one more, period for you. Don't worry, I can start another one. Let's see here. This is a long case, but answer may be quite easy. A 48-year-old male presents to the hospital with swelling of the abdomen and leg. So this is a case of edema, swelling of the abdomen and leg. He first noticed shortness of breath with exertion several months ago and has had a few episodes where he momentarily became lightheaded and lost the consciousness. So this is a case of syncope. Syncope presents like this. Person become lightheaded and lost the consciousness for a brief episode or brief period of time. Now the symptoms have been progressing with increased dyspnea and edema. He reports that he has always lived a healthy lifestyle and has no past medical history. There is no family history of any cardiac or pulmonary disease or any cancer. Such a good history, this type of cases do not only provide you with this clinical experience, They also teach you how to take history, how to present them to your examiner, or how to report them, He was born in Brazil and moved to the United States at the age of 43. He's 48-year-old now. So at the age of 43 only, he moved to the United States. Before that, he was raised in Brazil. Brazil is a South American country. He doesn't smoke or drink alcohol. On cardiac examination, the apex is displaced laterally. What does that mean?
Cardiomegaly.
Cardiomegaly.
Exactly. Cardiomegaly. Where is the normal position for apex? Where it is present?
Sir, fifth intercostal
Mid-clavicular
inside
Mid-clavicular.
mid
Very good. They're
left.
absolutely correct. Okay, just to revise ourselves, this type of question I've been asking, but I'm sure many students know this. On the left side, inside the mid-clavicular line, on fifth intercostal space is the apex, just inside the mid-clavicular line, on fifth intercostal space on the left side. So the apex is displaced laterally here. With an S3 on auscultation, S3, third heart sound, is present. And we know if third heart sound is present, probably the person has high chance of having heart disease or left ventricular disease. But sometimes this is heard in normal people also. But he's not normal. See that so many complaints are already there. Estimated central venous pressure is 15, and this is high. There are faint crackles at the base of the lung. So crackles or crepitations are also present. He has hepatomegaly with shifting dullness and bilateral pitting edema of the lower extremity. All the features of heart failure are present here. Hepatomegaly is there, shifting dullness means ascites is there, and bilateral pitting pedal edema also there. ECG is normal with no visible Q wave. So this is not a prior case of myocardial infarction. With infectious etiology is most likely responsible for this patient's disease. Such a long case, it's a good one to go through. Okay, but in the exam, when we don't have enough time, this type of cases really makes you nervous. But don't worry, just keep on reading. And when you reach to the last part, they've asked, what is the organism which is responsible for all this disorder? And when you see the options, it is crystal clear which option you want to choose. Just go through the option here. Mycobacterium tuberculosis, Staph aureus, Strep pneumoniae, Borrelia burgdorferi, Coxsackie virus, influenza virus, HIV, Paracoccidioides brasiliensis, Coccidioides amitis, Trypanosoma cruzi, Echinococcus granulosus, and Entaimba histolytica. Which one you think?
Trypanosoma cruzi.
What is
American
the
disease.
okay? Trypanosoma cruzi. So this here, no student is even telling me any other option, though there are so many. This is clear-cut case of Trypanosoma cruzi. Okay, this is American sleeping sickness. Okay, and the clue is Brazil. Remember that country, Brazil. He was from there, and Trypanosoma cruzi is very common there. He was migrated to US at the age of 43. So probably he was already infected with that. It's a chronic type of disorder, which causes what damage done to the heart? What damage?
Cardiomyopathy.
Dilated cardiomyopathy. Very good. Dilated cardiomyopathy. Excellent. So this is a clear-cut case of cardiomyopathy, dilated type. All the features are given. This patient is having heart failure, and the cause is a Trypanosoma cruzi. All other things are there to just make you confuse here. Okay, so long case, but important clues are there. So I should, develop that habit. Okay, and just to pick those important clue, then these questions are so easy to solve. Okay. So at the end, I like to request you all to like the video as much as possible, share it among your friends, and subscribe to the channel so that it will encourage me a lot for the future videos and recordings. Thank you so much.